one follow-up appointment I have had with that patient so far showed a significant reduction in the size of the nodule I treated. At 1 month, we had a 60+% reduction.
Wow.
And it was amazing. Reduction in volume.
Hey, it's me, Jen, again. And today we're meeting with Dr. Alireza Falahati in Salt Lake City, Utah to discuss thyroid RFA. Coming up. Dr. Alireza Falahati is a board-certified Mayo Clinic trained endocrinologist who has been managing a wide variety of thyroid disorders, including thyroid nodules and thyroid cancer, for over 20 years. He was extensively trained by some of the world leaders in the field of radiofrequency ablation and microwave ablation of thyroid nodules, and has been offering them to his patients for over a year now. He is one of the few physicians offering both RFA and microwave to his patients. He is the founder of Salt Lake City RFA Clinic. In today's discussion, we'll be covering topics such as training for RFA, when the treatment is necessary, types of nodules that can be treated, and much more. Welcome, Dr. Falahati. It's really great to see you again.
Thank you so much, Jen. It's a pleasure.
Yeah, just to give the viewers a little bit of background, we first met each other in 2022 in Baltimore at Johns Hopkins at an RFA training. And then it was a few weeks later, I saw you again in San Diego at the ACE meeting and also at the NASOI meeting. And a lot has happened since then. You've done several RFA training courses, and now you've integrated this modality into your practice. So tell me a little bit about each of those trainings, how they've prepared you for this, and what it's been like in your clinical experience with RFA.
You know, being a perfectionist, I really wanted to feel comfortable starting the RFA treatment for my patients. And to do that, I decided, let me find out where are the best possible treatments offered and take a look and attend as many of them as I could. So I started with my first RFA training, which was an amazing one done in Atlanta. And it was organized by RGS Healthcare. It was a cadaver training. So we really had hands-on experience after going over the initial theoretical part. And that gave me the comfort level after 2 days to feel relatively comfortable and have a better idea of what it feels like to really do the RFA on human body. Then the next course, of course, was at Johns Hopkins. It was fascinating to learn more details about RFA again, who is an ideal patient, how to set it up. And also, having attended the first one, there were a lot of questions that had come up that I was able to ask at the second meeting at Johns Hopkins. So coming out of the Johns Hopkins training, which really re-emphasized what I had learned from the first meeting, I was almost ready to get started. But I still felt like a few practical aspects are missing. So I attended another training, which was being offered in Orange County, held by an endocrinologist who is very busy and does plenty of RFA procedures in his private practice. And that was very eye-opening to see how in real life it is being done on real patients. And again, I was an observer at that point and watched quite a few, about 5 or 6 procedures being done on one day. I really paid attention to the setup of the work environment, of the procedure environment. And that was really important for me because, knowing how to do it is one thing, but knowing how to prepare your procedure room was another thing. And then ultimately, the course in Brazil held by Dr. Rangel and his colleagues. And again, at that meeting, I felt surrounded. I was surrounded by some of the world leaders in the RFA field. There, I was not only able to ask all my questions and review the theories and really the final touch-ups I needed, but also we went into a local hospital and practiced personally on real patients who needed the treatment, and that treatment was being offered. And we, under the supervision of these highly experienced individuals, were able to perform the procedure and really feel comfortable doing it. So that was my journey in terms of RFA training. Then I had also a training in Germany, in Berlin, on microwave ablation of thyroid nodules, which is a very similar procedure, slightly different technique. But that was also very helpful to get comfortable with the microwave treatment of some nodules. And by the end of all these trainings, I felt 200% qualified and confident to start my procedures in my own practice.
That surely is a lot of training. And I imagine that training where you were doing actual live cases down in Rio was absolutely incredibly helpful. I've heard other physicians say that it is.
Yeah. It was a very unique experience, and it was far beyond and above what I expected. I really, by the time I was done with that training, I felt very confident, not stressed at all about doing my next procedure, which I did shortly after, a few days after.
Wow, that's awesome.
The first procedure, of course, the biggest challenge was to convince my patient that even though it is my first procedure, but I have been highly trained and overqualified to do this procedure.
Right.
And I had to reassure my patient, believe me, I have done previous procedures, but as part of my training. And also, fortunately, one of our highly experienced friends and trainers came to Salt Lake City to be there for my first procedure, which is Rudy, someone we all know. And he has been an amazing support. So he came to my first procedure, was there, and really made himself available for the entire procedure to just make sure in terms of operation of the equipment and preparing the nursing staff, etc., all those details are really covered. On my end, doing the procedure was very easy. It went very well, and it was highly successful. One follow-up appointment I have had with that patient so far showed a significant reduction in the size of the nodule I treated, and she's doing very well.
You know, patients are always so excited to see how much their nodules shrink. And I think that their favorite thing is the percentage, you know, because when you measure the dimensions, it's one thing, but when you see the percentage, like when you get that number, 50% reduction, you know, it just, you see their eyes light up.
At 1 month, we had a 60+% reduction.
Wow.
And it was amazing. Reduction in volume again. And the patient was feeling significantly better in terms of swallowing problems that were present originally. They were completely gone. But I told the patient that the shrinkage in the size of the nodule will continue, and this is not the end of the road yet. So she was very excited.
60% in a month is incredible. I think it took me quite a bit longer to get to that point with mine, but I remember just shortly after my procedure feeling a significant difference, just with a little bit of reduction. I could tell improvement with my swallowing, improvement with my voice, and even I was taking tape measurements of my neck. I could see a huge difference in the size of my neck. So all very encouraging things for patients who are tracking their progress. So tell me about how many cases have you done?
So far, I have done 2 RFAs, and keep in mind the Brazil training was in end of November, beginning of December. So now we are in February. So within the 2.5 months, I have been back from that training. I have done 2, and there are 2 more scheduled. And I have done also 1 microwave ablation. So I think as the word of mouth goes around, more and more patients are interested in finding out about it and considering it.
Who do you think should consider this procedure, and when is it just unnecessary?
Tons of patients out there with thyroid nodules. As we know, the data showing the development of thyroid nodules during a person's lifespan and the likelihood of pretty much everybody developing a thyroid nodule is pretty high. Now, does everybody need to have an RFA? Absolutely not. Who is a candidate for an RFA? I believe if a patient has thyroid nodules and the nodule is large enough to cause either symptoms, which we refer to as anterior neck symptoms, or triple D, dysphagia, dysphonia, and dyspnea, or shortness of breath, difficulty swallowing, or changes in voice, then that patient definitely should consider RFA after confirming that the nodule is benign. So to confirm the benignness of this nodule, of course, we need 1 or 2 fine needle aspirations of that nodule to confirm it is 100% benign. And then we can go ahead and move forward with planning for it. So if the nodule is large enough to also be noticed, that's another aspect of it. Many patients can see it, and that is really psychologically bothering them, but they are not having any symptoms. So that would be another aspect, because we are going to create or cause a significant shrinkage in the size of the nodule. We're talking about 70 to 90% decrease in the size, in the volume of that nodule. And that makes that visible nodule become invisible without any surgery. Many patients don't think about the long-term ramifications of undergoing surgery. And again, don't get me wrong, there are many patients who really need to have surgery because of the nature of their thyroid nodule and many other aspects of it. But after looking at the nodule, having a detailed discussion with the physician who performs the RFA, I think if it's a go, that individual patient who is a candidate for it will really benefit from it.
And especially with you being an endocrinologist, the nodules that are actually producing excess hormone are really messing up that patient's hormone.
You are absolutely right. Yes.
So talk a little bit about treating those kinds of nodules.
Yes. So in the past, if a patient would come in with hyperthyroidism or an overactive thyroid, or even borderline overactive thyroid, and we would do a scan of the thyroid, the scan would show that this patient might have a hot or toxic nodule. We would send the patients to radiology for radioactive iodine treatment. And many of these patients after the treatment would develop long-term permanent hypothyroidism. They would lose their thyroid function. Again, it also involved some degree of exposure to radioactive iodine. Now with these new technologies with RFA, we can selectively target that one nodule and treat it and turn it off permanently without affecting any other aspect of the thyroid. And by doing so, we are going to save the thyroid function, prevent the patient from being exposed to any form of radioactive iodine, even though the dose is generally low and relatively harmless, but still it's a radioactive iodine treatment. And also the patients will see results relatively fast and almost immediately within a few days, as opposed to receiving the radioactive iodine and waiting for months to see the results. And in many cases, the treatment fails and they need to go in for a second treatment or ultimately consider surgery. RFA really is going to save them from undergoing surgery or having radioactive iodine treatment or any of that in a very effective and targeted manner.
I didn't realize that radioactive iodine had to be repeated frequently. I didn't realize there was that much of a failure rate, which when you think about it, most people who have thyroid nodules are women, and most women have children. And a big concern for the patients in our community is that they are going to be separated. They're going to need to be separated from their children during that time. And what is the consequence of my radioactive, consumption going to be on my family and that time away from my family and all? And then to consider, like you said, maybe having to even repeat it. I can only imagine that tremendous numbers of young mothers would be very much more interested in this treatment option than in radioactive iodine.
I think so, and I 100% agree with you. Yeah, that is one of the biggest concerns. I mean, usually men or women who are past menopause and don't have young children are not as concerned about it, even though, again, there is a significant downside to considering radioactive iodine treatment even at that age. But younger women with families and kids, they are very concerned about exposing their family to some radioactivity. And because of that, there is a significant hesitation. Also, young women who are planning on having more children,
Right.
they need to really pause their family planning for at least 6 months before they can resume and work on pregnancy and breastfeeding, etc. afterwards. So there is a significant limitation in terms of their ability to be around their family, take care of their kids for a few days, and also their plans in terms of another pregnancy maybe down the road or in the near future. So those are definitely huge concerns. And I think if a person is in that category and has those concerns, should definitely consider talking to an RFA physician, perform the procedure rather than considering the traditional way of treating it.
Talking a little bit about with breastfeeding, this is a question that frequently comes up in our community. Is it okay for me to have RFA while I'm breastfeeding?
So RFA is really a very safe method of treating a patient. And there is some electric current going through the body during the procedure, which is going to be for just a few minutes pretty much. And after that, the patient is done. It is not going to affect any aspects of their safety of breastfeeding their children or their baby. And also, it is not going to be of any concern whatsoever being around your children. So I think, honestly, again, that will be another huge plus. There is absolutely no contraindication to consider doing RFA during breastfeeding. I would encourage everybody who is concerned about that to consider RFA.
I definitely think that the main reason why patients are a little bit concerned about is because of the fact radioactive and radio frequency are similar words. And so maybe they kind of think that radio frequency includes some sort of radiation exposure, but it does not.
Absolutely not. No. Radio frequency is just an electrical pulse that goes through the body, and it generates heat around the tip of the probe that is inserted into the nodule. So it's very, very specific and localized, just electric way of or method of burning the tissue around the tip of the needle inside the nodule. That's about it. There is no radioactivity whatsoever. So the term radio frequency and radioactivity, you're right, sounds similar, but they are not even close. They are completely different.
The long-term ramifications of a full thyroidectomy and radioactive iodine are going to be that permanent hypothyroidism, which is going to result in a need for thyroid medication for the rest of the life. And potentially, if you have any kind of issues with your parathyroid, supplementation for calcium, all sorts of other unintended consequences that sometimes come along with thyroid surgery. But
Absolutely.
looking at RFA or any of the thermal ablation procedures, there really are no long-term ramifications, except that you have to continue following up, keeping an eye on that nodule with ultrasound, because it doesn't completely go away. It just reduces in size, but you keep on following it up, and that's basically your long-term ramifications. That, and you have a lessening of your symptoms.
You are 100% right again. And, the long-term consequences of having surgery, not having a functioning thyroid are significant. And, there are patients who really have no choice and they have to do it for other reasons. But if you have a choice to choose between a lifetime dependence on thyroid medication and losing your thyroid completely, whether it is the thyroid physically being removed or with radioactive iodine being damaged and turned off permanently, if you can avoid that by undergoing a procedure that is going to be anywhere from 30 to 60 minutes, maybe one time, and you are done, that is a big difference. And I think it's a no-brainer that pretty much everybody should consider, at least look into their options and educate themselves and then make an educated decision. Because really, you need to discuss all your concerns with your physician. And it's a teamwork. You need to share your concerns, and then the physician will guide you, hopefully, the right direction and tell you what would be the best option. But in this scenario, radiofrequency ablation is absolutely the best choice, and it would prevent the patient from having so many other issues down the road.
Unfortunately, right now, we are still in the early days and years of thermal ablation being available in the United States. And what we encounter a lot in our Save Your Thyroid community is that a patient will go to their local provider, their family care physician, and mention having a thermal ablation procedure, and that provider will either not know anything about it or advise them against it. And then they come to our community and they're very concerned. They're not sure if they can trust this procedure, or they feel conflicted because they're not sure, can I trust my provider or do I go and do my own research? What I always tell patients is, you can't know if you're a candidate for this or not until you speak to someone who does it. And so I always tell them, we have a list of providers that do this in the United States. Contact the one closest to you or contact the one that you're interested in the most and see if you can consult with them, and they'll let you know. And so, do you offer any kind of telehealth consults for people who are maybe wanting to travel to see you?
Absolutely. And actually, your timing is perfect right now, because over the past few days, I have been contacted by a few patients who are from out of state. They don't live in Utah or near Salt Lake City. And their question was, first, Dr. Falahati, I have thyroid nodules. They are large. My doctor has suggested surgery. But when I asked my doctor about RFA or any thermal ablation, my doctor said, no, those are experimental, and was not interested in helping me. So what can I do? Is there any way I can talk to you or set up a telehealth? And those are definitely cases where I immediately initiate contacting them and setting them up for a telehealth. And after the telehealth and gathering all the data I need, or ordering some of the tests, for example, the thyroid ultrasound, some biopsy reports that I need from their local hospital or local physicians, and reviewing it with them, then I will tell them, yes, you are an excellent candidate and you should not settle for anything less than that. You are more than welcome to fly to Utah or to drive to Utah, and I would be able to take care of you. Or you are living in an area where someone I know and is highly respected and fully capable of taking care of your issue right next door to you. So why don't you contact his office? And I even sometimes initiate the referral to that physician. But you're absolutely right. Your website or RGS's Instagram or other resources, there is plenty of places where one can look for RFA centers these days. They just need to reach out, ask someone who does it. And you're absolutely right. If you ask someone who doesn't do the procedure, there is a really good chance of that provider telling the patient, no, this is not for you, or don't consider it. It all depends on that individual's preference and bias. But if they talk to someone who does the procedure, I think they will get a more objective answer and be potentially considered.
Any doctor who provides this is not going to just say yes to every patient. They're going to turn some patients away that are clearly not meant to have the procedure, because that's not good for them or for the provider. Getting that feedback from someone who has the training, particularly, you've been to all of these different trainings and you've seen the types of nodules that are appropriately treated with thermal ablation, is key. My personal experience with my local physician was that he was absolutely 100% against it. It didn't really slow me down. I was not the least bit deterred by his difference of opinion, but I know a lot of patients battle with that concern of especially with a physician that they've trusted for a really long time. They don't want to go against that physician's opinion, but it's really important now that we have new emerging treatments that patients understand that not all physicians know about this yet. Yeah. So, thank you for being one of the first ones, here in the first few years of this being available to take this on, because I know it's not an easy thing.
I was at a national meeting just a few years ago, and I was approached by some of the companies that were offering the first generation of RFA equipment. And they were telling us about how advanced this procedure is and how popular it is in Asia and other parts of the world. So I asked one of my colleagues who is highly experienced in management of thyroid nodules at the time and said, so what do you think? And he immediately just dismissed it. He said, no, I don't like it. I would not do it. So that's delayed my development of interest in this procedure by about 2 years. And I wished I wouldn't have talked to him back then, because I would have had a much longer head start if I would have looked into it at that point.
It really does matter, when someone you respect has a difference of opinion. And that's why it's not that it's not important to get opinions from people you respect. That's always very important. Yeah. But you have to take your own approach to understanding it and thinking about it and really make your own decision based on the data. So I'm really glad that you finally, after that delay came around. Let's talk a little bit about training physicians. Is this something that you think you want to do now that you've done all of these training experiences?
Yeah. I am looking into that option and I'm very interested. Based on my experience, I think I can be a huge resource for younger physicians who are interested in doing the training. Also, in terms of our facility, we have an amazing setup, which will be ideal for potentially bringing in young physicians, mostly head and neck surgeons or endocrinologists or interventional radiologists who are interested in learning the procedure to do it in their own practice and share with them my experience, teach and train them, and kind of condense what I learned at these 5 different meetings into one and try to make it as effective as possible.
Well, how is this changing your practice? I mean, you're an endocrinologist, you're helping patients who are managing their hormone levels. Are you handling diabetes patients as well?
Just thyroid? No, we see all kinds of, so I and the team of 7 additional providers working with me in the same medical group, we are very aggressive with treating different medical conditions, whether it is diabetes or thyroid or adrenals or pituitary issues. But over the past few years, my attention has been drawn to more and more thyroid nodule and thyroid cancer management. I have even blocked 2 days of my week. So instead of seeing just patients, I only do thyroid ultrasounds, FNAs, and RFAs on those 2 days. So literally 40% of my practice has now converted into thyroid nodule and thyroid biopsy and the procedures related to it, which is going to enable me to bring in more patients and focus on this specific condition. So going forward, I think, so in the past, I would see patients, I would discover the nodules, measure them, biopsy them, confirm they are benign or malignant, and then come up with a treatment plan. And usually the treatment plan was very simple. If it's cancer, go see the head and neck surgeon for your thyroidectomy. If it is not cancer and you have no symptoms and you're not bothered by it, let's watch it. And if it is bothering you, then let's again send you to surgeon. But now I have this amazing alternative, which I'm really excited about. And this is going to be my new area of practice. And I hope I can get more and more into it and also learn. I mean, we are all learning as we go about new indications for thyroid RFA. For example, treating small papillary thyroid cancer cases as is becoming another area. And I am considering potentially one patient already to do that. The other area would be treating parathyroid adenomas or enlarged parathyroid glands causing parathyroid overactivity. And again, that would be a case where we would send the patient to surgery usually.
Right.
But nowadays, I do the ultrasound. If I find one single parathyroid adenoma on the ultrasound, I do offer that to my patients. And one of my patients is considering it right now. She would be a prime candidate to have the RFA done and avoid the whole neck surgery, parathyroid surgery, and exploration of the neck. Again, that would be another new indication. So we are learning as we go, and there will be, I am sure, in a few years, much more indications for this procedure or for thermal ablation in general with all kinds of options we have these days. And it's a very exciting era to practice medicine in.
With the parathyroid adenomas, if they were going to be removed surgically, does that involve removing that side of the thyroid too? Or can they just take the parathyroid?
They can selectively take the parathyroid. So nowadays, the head and neck surgeons are actually amazing, and they most of them perform the so-called minimally invasive procedure, where with a small incision, they are able to go in and remove that parathyroid gland, which is most of the time hidden behind the thyroid or in the lower part of the thyroid. So they don't always have to remove part of the thyroid, but some of these adenomas are, believe it or not, located inside the thyroid.
Right.
So that's when part of the thyroid will go with it if it is removed.
So, but when you have the ability to do RFA, that's completely still treatable.
That is a complete game changer. So again, that nodule, if it is a one single nodule that we are seeing inside the thyroid, and we have confirmed this is the parathyroid gland, and there are different ways of doing it. But once it is confirmed it is the parathyroid gland within the thyroid, we can pretty much treat it like a thyroid nodule. We can just go in there and treat it with RFA or thermal ablation and cure the disease without surgery.
We've had a handful of patients ask about that in the community. What we're really seeing a huge uptick in, though, is requests for cancer to be treated with RFA. And I know that that's kind of a new thing and that it's not available everywhere.
In terms of thyroid cancer, the most common type of thyroid cancer is papillary thyroid cancer. And that's the kind of cancer that we are currently treating with radiofrequency ablation or thermal ablation if needed. And the indications for doing this procedure is if we know for sure that the cancer is limited to one small lesion inside the thyroid or to one single lymph node. Let's say a patient has had thyroidectomy years ago. Now one single lymph node is positive for metastatic disease. Then we can go selectively in and treat that nodule or that lymph node and be done. So that's another great indication for this procedure, and to avoid going back in, removing more tissue and more thyroid material where it can be avoided. There is a lot of research going on at this point to kind of figure out when and where should we consider this procedure. But at the current time, if we are talking about a small single area or nodule inside the thyroid, or one single lymph node that is confirmed to be metastatic, contain metastatic material from papillary thyroid carcinoma, those lesions are perfect candidates for RFA.
Yes, we had actually a session about RFA at the THICA conference last year, and I got to be a part of that conference by moderating a discussion on RFA for both thyroid cancer and metastatic lymph nodes, like you were just mentioning.
Yeah.
And there were a number of interested patients that viewed that session and also came back and watched the recording later. So I know that this is going to be a really big part of the, as you said, the indications that are ever expanding for RFA. So it's very exciting to see for patients to be able to save their thyroid or to avoid subsequent surgeries after they've already had one. So do you have any final thoughts you want to share with the viewers before we wrap up our time together?
You know, I think the key here in terms of really optimizing the care that we are providing to our community is, one, to educate our patients and give them the best option. In order to do that, we as medical providers need to be educated ourselves and know exactly what we are talking about, what the indications are, and maybe go out in the community and educate the many primary care offices that are around us. Definitely. And are advising our patients against these type of procedures, because they are still believing in the traditional ways of doing it and not knowing enough about the new procedures. So I think educating providers and the medical community would be a huge challenge and needs to be done sooner or later, but also educating the public through social media, through amazing advocates like yourself and other resources to get the word out and to let people know there are other options. And if your provider is not offering it to you, initiate it yourself and start looking.
And what is your Instagram handle? Because I know you're very active on Instagram.
So it is the name of my RFA or thermal ablation clinic is Salt Lake City RFA Clinic. But the Instagram name is SLC RFA Clinic.
Follow Dr. Falahati on Instagram. Thank you for joining me today. It's been a pleasure catching up.
It was my absolute pleasure. Thank you very much. Have a great day.